Hello again. Welcome back to the Senate Government Operations Committee and our meeting of January 23rd. It's a Thursday. And our final witness of the day will be Drew Hazelton, who's chair of the Vermont EMS Advisory Committee. You can certainly join us at the table, Drew, and for the benefit of one new member, we'll go around the table just to introduce ourselves.
Hi, Drew. Senator Larry Hart, Orange County. We met yesterday.
You've been up 2 days in a row.
It's him.
You are not. Alice, Pleasant Winter District. It's good to see you again.
Brian Collin with the Rutland District.
Jillian with committee assistant.
Thank you.
Oh,
Make sure I never forget.
it's not that you forget, it's just a weird rotation.
Yeah.
You know?
It's okay. My eyes help.
Yeah. Senator Tanya Behovsky and Senator White from Windsor County.
Nice to see you all again. Thank you for inviting me in to talk about EMS a little bit.
Sure.
So you guys did some things last year for EMS,
We've been doing some things
Yeah.
every year for EMS.
and we really appreciate it. So one of the things that changed this year is that the report that we have traditionally had to submit, answer the same 14 questions, we don't have to submit this year because we're doing some additional work. So I did send a letter just to kind of give everybody an update as to the work that we were doing, which you have, but I'll kind of go over some of the highlights. So last year, well, for the last 10 years, I think I've been sitting in this committee and I've been asked a lot of questions that quite often I have to say we don't know the answer to, because we really don't know the state of EMS. We know that EMS in Vermont is in trouble. We have some examples of that around, but the bill from last year was looking for a comprehensive evaluation and assessment of our EMS system. So we have been working with the health department. We've finally gotten to the point where we have a contractor that's helping us get that information. And the reason we needed that help is because there's no single source for data about EMS. As many of you know, all of you probably know, EMS is delivered in so many different ways that there's no single place that we can go get this information, and really no easy way to compare that information. You kind of come up with the answers to the questions that I've been asked that I can't answer, which would be, what does it really cost to deliver EMS in Vermont? You know, what does the true workforce challenge look like? How many people do you need? Some answers that we haven't been able to give you. So we are optimistic that the process that we've started now will allow us to provide you with that data. The contractor, we've given them until the 15th of April to conduct the data assessment for us. That report, if it is due back to you by next December, with a comprehensive statewide EMS plan for the following year. So we are in the process right now. Our committee is laying out the next phase of what we're doing, and it's broken it up into the kind of data collection component, and then the development of the plan is the second piece, so that we can kind of deliver on that. Hopefully we'll be ahead of our December 26th schedule for the EMS plan. So with that, there were a couple of pieces that were specifically called out, which was for the EMS advisory committee to work with the public safety telecommunication, the dispatch task force, whatever that really long title we gave them was. So our work and their work intersect a lot. But what we're not doing is we're not redoing their work. So we've met with them, and they're going to keep us up to date as to the work that they're doing, and we'll be incorporating the information they have into our reports. But we're not going out and trying to reinvent the dispatch study, since that work is being done. We have reached out to the regional governance committee that was created last year, and they told us that they were not quite ready to have a conversation with those two as they were organizing. So we'll be following up with them over the next couple of months to try to coordinate with that group and kind of their thinking. We did reach out to the Green
You're looking for the new co-chairs.
Oh, congratulations.
Thank you. It was by default, not that I didn't want to do it, but.
So I'll be reaching out to you to hopefully be able to coordinate as we move forward with our 5-year plan. So that's really the point where we're in discussing governance more so than we are this current phase that we're in, which is really assessing. where we're at. So, we're at the top of the Green Mountain Code Board. They've been in and, we've been working with them. They're going to be attending our meetings to help, make sure that we're coordinating with kind of the direction and stuff that, they're heading. We've had the commissioner in to make sure that we're kind of following the similar path to where the, health department's heading. So hopefully, as we kind of put this all together, we're all pushing in a similar direction for kind of the future of EMS, which I think is a huge step in the right direction for us, and something we needed for some time. As we do the work, the conditions on the ground have not gotten a whole lot better. So we still have ambulance services and first response squads that are struggling to get personnel, struggling to respond to calls. We have challenges around access to education. So we know that to be true because we experience it. What we can't do for you yet is quantify it. And we're hopeful that we'll be able to do that when this study is, or this assessment of our system is done.
Yes, the Senator Clark.
For Larry's education training. Is primary, yeah.
Yeah,
For the-
I got that in
Okay, good.
health and welfare. That red line.
That's the house. That's not house being called over.
Okay, that's how it's spelled. There's also, just to let you know, there's a lady that was completely wigged out on drugs out here, and I just reached out to the Capitol Police.
There's a what?
There was a woman out here, completely, she was wearing that big long coat, that really thick coat,
What? Oh,
and she was completely wigged out on drugs. So I talked to the chief of the Capitol Police, and he says, yeah, he said, we've been watching her very closely. I said, well, she's even worse now. And he said, yeah, I'm keeping it. We're gonna go get
Yeah,
Narcan.
they're.
We're gonna get Narcan just in case she thinks that she was in the woman's bathroom and did drugs in the bathroom.
Thank you.
So he's just want to let you know ahead of time that they're, you don't have to do your job today. They're doing it for you.
Excellent.
That's their job.
That's their job. So yes, he witnessed it too.
Thank you.
Yeah, I just said, I went to him, I said, she's in bad shape, and he goes, yeah. So,
So some of the other details that are a little bit harder for us is we're looking at reliability in our EMS system. So we've talked about some areas where ambulance services don't arrive and mutual aid having to cover, but we're also looking at the quality of EMS being delivered. So that's something that we've never really been able to speak to before. So we're using some quality standards to measure whether we're actually providing consistent EMS delivery across the state, whether the healthcare that we're providing is appropriate enough to the standard. So again, it's kind of exciting for us. Another thing that was part of the legislation that passed last year was an increase in the special fund. So from 150,000 to 450,000, with 150,000 of that increase earmarked towards helping the advisory committee do the work that we were assigned. And that's what we've used to hire some assistants. There was an allowance in the bill to use up to $370,000 this year to complete that work if we needed to. We are likely going to need to extend that deadline past the end of the fiscal year because we're probably gonna need more money in the second phase of this, which would be developing that 5-year plan. That makes sense. We're gonna have the assessment done before the end of the year, but kind of the next big chunk would be happening next year.
Oh.
So we may need some language change. I don't know exactly how that works, but the way it was written last year, we had to have all the work done this year in order to use the money. And realistically, we know it's going to take us longer than that.
Okay, and the special,
Senator White.
thank you, but the special fund, you can only use it till, so it's not necessarily an increase in money, but just an extension of the deadline?
Yeah.
Okay. I
Oh,
understand.
that's an important.
Yeah. So the allowance only allowed us to use the money for that purpose from this year, because the special fund is earmarked towards training. Could be accepted.
Right.
This year.
So reasonable.
but again, we want to make sure that what we're giving you back is a good quality piece of work, so you can make those decisions.
Senator Hart.
Yeah. Drew, where do you get where's most of the funding come from? Does it come from the state and it come from local municipalities, or how does it?
For what?
For your job
So,
or everyone's job?
so that, yeah.
One
that-
is different.
Yeah, well, it's a great question. So EMS is a patchwork, and that is not just in Vermont, that's across the nation. So in some areas of the state, EMS is paid for completely through municipal budget. And then they take whatever revenues generated from insurance that kind of goes back in their general fund. In other areas like where I am from, EMS is provided by a regional nonprofit. And we get an assessment to the towns, but the majority of our revenue comes from billing. For us, it's about 80% comes from
Medicare, Medicare, that thing.
we have several services in the state that are completely volunteer, that don't bill insurance, that fundraise 100% of their operating budgets. And we have about everything in between. So, depending on where you are, EMS is either, so we have 2 for-profit ambulance services in Vermont. Everything else is either nonprofit or municipal, nonprofit being the largest component or number. And then we have some third-party third service model where town has a standalone ambulance service. We have some that are the ambulance services embedded in the fire department. We have one where EMS is part of the police department. So, if you can dream it up, we probably got one in
Got
Vermont
EMS for you.
that matches. And that's part of the challenge.
Would Rutland be a good example of both? Where they have sort of a subscription fee every year for people to just mail them checks, but they also, on the ballot on town meeting day, they get a chunk of money.
Yeah, so
municipalities.
Rutland is a regional nonprofit, so they do receive
Rutland Town, Rutland City.
Rutland Ambulance Service.
Yeah.
And the towns around Rutland.
So it services all the towns in Rutland?
It,
About all of
No.
them, a lot
so
of
like Fairhaven has their own, I don't know where the town lines are, Brandon has their own service. Mount Holly used to, but they went out of business. Ludlow has their own service. So regional ambulance serves Rutland, West Rutland, and the kind of communities, these are Killington. So they get a assessment from each of the towns, and then they do bill insurance. The subscription programs are a kind of an interesting thing that carried over from the late 60s and early 70s to offset the cost of delivering EMS. And what those are is it's really a pool of members to help offset deductibles and copays. So we run a very similar program, and the way that we have to run it is we charge $60 per household, and that money sits in an account. And then if anybody in that pool uses the service, then we have to then move that money from that pool to pay their bill. So it's not really insurance, it's more pooled money. And there's a specific allowance that allows ambulance services to do it. Most of the nonprofits have a model like that in Vermont.
Okay.
And it's a way to help protect especially the fixed income people from and people that are underinsured from large ambulance bills.
Jim
So-
Finger still running?
Yes,
Good.
Oh.
yeah,
That's good, man.
I'm sure he'll be up with me here at some point if we get invited back. So that's kind of the EMS advisory. Yeah, I'm sorry.
So you can go ahead.
No, one of the big issues, because this is now touching on it, is reform of payment system. How are we've made progress on that. And I know it's an arc, but how are we doing on that? Because that was one of your biggest and most important issues, that and the volunteers and the lack thereof.
Yeah, so EMS is still, if you look at it from the federal perspective, which is kind of where we live most of our life because of Medicaid, Medicare patients, we're still a supplier of transportation.
Mhm.
So, which is unfortunate because we do so much more than that. In the late 1960s, you were getting picked up in a hearse and taken to a hospital, you were transportation. I would argue what we're providing in the back of ambulances now is very clearly healthcare.
Oh,
Um,
Yes.
especially considering the level of care. But the,
And particularly given that we know that people's outcomes are totally dependent on how quickly they get care.
yeah, and like I said, we have technology, for example, in our ambulances, we have ventilators, ultrasound, EKGs and cardiac monitoring. So the same level of services that you're seeing in your ICUs is what we're delivering in ambulances, because that's what's necessary on these patients from one hospital to the next. So it's not just transportation, but the funding mechanism that exists for ambulance services is still straight out of, 40 years ago, because that's just how it exists in the federal world. So we have been successful in the 10 years, I think, that I've been coming here at moving the Medicaid number in Vermont, which is the one that you're in control, up. It is not automatic, so we haven't seen an increase in that in the last couple of years. So it's not keeping pace even with the Medicare numbers in Vermont.
It's not keeping pace with anything.
But I will say that, I think I mentioned in the other community, New Hampshire is looking at very similar things to Vermont. They are a little bit ahead of us in their assessment of EMS. They actually tasked the Department of Financial Regulation with doing a cost assessment for EMS. And I'm glad to share the report with you if you would like to read it. It came out about 2 weeks ago, and determined that in order for EMS to be sustainable, all payers would have to pay 202% of the current fee schedule. In order to make EMS financially viable in the state of New Hampshire.
And how applicable would those results be here?
I would be shocked if there was any difference between Vermont and New Hampshire, when you look at the actual cost of delivering services. So we're going to get a little bit more data. We were charged with looking at the cost. We're not charged with looking at it in the detail that New Hampshire was, and certainly having that study done by DFR over there. They dug into it a lot more than, we're gonna be able to dig into it here. So, we're still behind. We're still not covering the cost of services. Part of the legislation last year directed Medicaid to pay for patients that are treated but not transported. There was some question about the wording in the legislation. So they are paying, but they're paying at the BLS hospital to hospital rate versus the BLS emergency rate. So they're paying about half of what ambulance services expected based on the testimony and conversation from last year. So
Are we having to do a clarifying bill on that?
it would be appreciated to
Have
clarify.
have you asked us to do that yet?
I haven't asked you for anything yet. I've been providing you the information you asked for.
Wasn't it also true that the bill didn't get paid too quickly sometimes?
Yes.
So there's always challenges in, getting information and, as far as the definition of what is paid for, what is not paid for. So we've been talking again over the last couple of weeks as I've been meeting with folks saying that there has been some difficulty with interpretation. So EMS is paid really in 4 primary billing codes. So we either do BLS emergency or BLS non-emergency. And the non-emergency would be what we would charge when we go from one hospital to another, or we do ALS emergency or ALS non-emergency. The ALS emergency would be anything that comes in through 911 that results in, advanced level procedures, and the ALS non-emergency would be the billing code for when you pick up a patient at a hospital.
And
take it to another.
AL stands for.
Advanced life support, sorry. Basic life
The other
support,
one was
basic life support versus advanced life support.
advanced.
So this is one of the challenges that you'll hear from hospitals, which is getting patients from one hospital to the next is very difficult. Ambulances are quite often not available. Part of that is the reimbursement rate to move patients from one hospital to the next is quite often so low that it doesn't cover the cost of doing the service. So if you're trying to move a patient, so for example, a mental health patient that needs to get from Burlington to the Brattleboro Retreat, the net loss for the ambulance service provider would be huge. Which is why those patients just didn't get ambulance transport. So one of the things that we did at Rescue, has nothing to do with the advisory committee, is we worked with Retreat, we came up with a program so that we can transport those patients with additional financial assistance from Retreat to help cover the losses. But that's part of the challenge that we're facing in our EMS transportation system, is that getting from one hospital to the next, those rates are so low that is quite often doesn't make any sense.
Yeah.
So if I get a phone call, like we quite often do, to, for us to go over to Bennington and pick up a patient and move them to another hospital, I could, but I can't afford to lose $200 in the process of doing it. So it is
So
challenging.
you say no.
So you have to say no. Yeah. Like this is,
Did you find out if you're gonna get those 2 ambulances that you ordered?
I doubt it anytime soon. So, and we're talking healthcare, is the cost of delivering of services has gotten more significantly more. And, I was telling them, like, I ordered ambulances at this point, I think we're 3.5, maybe we're pushing 4 years ago, that have not come yet. The cost of these trucks is, it depends on what period of time you look at, but you're looking at almost double since the end of COVID, what we're paying for ambulances.
What does a good new ambulance cost with that? With a home health?
You can start the cheapest ambulance out on the market, you might be able to get it for $150,000. And for most of what you're probably seeing driving around Vermont, you're $250,000 to $300,000. And that's just the ambulance.
Yeah.
The stretcher that's in the back of that ambulance is another $50,000. And if you haven't upgraded your stretcher, you can't put old stretchers in new ambulances. The standard chains and the mounting brackets that were used in the older ambulances can't use the new ambulances. So we're in that cycle. So it's very expensive to put ambulances on the road and keep them on the road.
So just for your benefit, Drew, I think I'm understanding, there's different sort of studies going on. This Emergency Medical Services Advisory Committee is one. Then there's the dispatching group that's charged with finding out all about that. And then the third one is this county governance sort of model. And again, just for your benefit, say by default, because I'm chairing this, I have to, saying that the wrong way, I'm delighted to be able to jump on that committee. And I've asked both Senator Harrison and Senator Norris, who were on it, whether they wanted to be reappointed. They both did. So there's the 3 from the Senate side. The House has a similar situation where one of the chairs didn't get reelected. So Matt Lyron is by default the chair on the other side. Mark Higley, I think, was the second person. And the third person on that committee also did not get reelected. So I don't know whether the speaker has put forth another name or not, but those are the 6 people that, and then you were on the technical advisory committee, I think, right? For that group. It seemed like your name came up.
Probably.
And then there's a Campany chap from down your way.
Chris
Yeah.
Kennedy.
Yeah. Or maybe it's Wyndham.
He's Wyndham. Also,
LPC.
Okay. So the long and the short of it is the last meeting, and I spoke with Senator Hardy this morning. She kind of had a list of things that she didn't kind of get to last year. They haven't met since October. And there's a report that's due, I think, by next November, something like that, or November of this year. And I don't know that we're going to be able to get a report done, because I think they only met 3 times. They had a limit of 10, so we had 7 left to do. Anyway, that's all to be determined, I guess. That's what it put.
Yeah.
Well, it's an important part of the conversation about what the future life plan look like for
Yeah.
EMS. So I think there's as we get the assessment numbers in, and we're able to really more quantify what our EMS system is doing, I think we're gonna be able to identify, the gaps and hopefully put together a plan to fill those gaps and try to, make sure that education for EMS providers is available, that, people call an ambulance, it is available. When I was talking with the healthcare yesterday, something happened to us many days ago. It never happened before. We got called to a town and we were the 7th ambulance service that they called.
Wow.
Before they could get an ambulance. Our crew was on the road for 58 minutes from when they went out the door until they got to a patient. So like, this is
Just think of the outcomes that are
Like,
affected
this
by
is-
that.
like, I can't tell you with data because we don't have, it's not done yet. But I can tell you from experience that our system is still struggling.
Yeah.
Let's say when you call 6 different services and you're at the 7th one in line
So-
trying to get,
Were they, the other 6 unavailable?
so this is a challenge, yeah. So we have a system that is fragile. So in some areas you have you may have an ambulance service that has one ambulance, or maybe they have multiple ambulances, but they only have one crew. So when the second call comes, or if, for example, some things that we're experiencing, our patients have to go further away than they ever have before. So based on hospital capacity, it determines where we have to go. So 2 weeks ago, the closest MRI machine that was available for our area was Portsmouth, New Hampshire. So
We have a great new MRI available, and they say it's available a lot in Springfield.
so this is a challenge, right? Because
Oh, that's right, it's not that close to you.
it's closer than Portsmouth, New Hampshire.
Yeah, it is.
And so we're taking
Wait,
patients to Southern Connecticut, Rochester, New York, Portland, Maine. So, as the hospital capacities for certain specialties aren't available, there's an impact. So if I send an ambulance crew with a patient, to Rochester, that means they're not available for a long time for anybody else.
And MRI, you should remember Springfield has a brand new one.
Well, it's not up to us, it's up to the hospitals, but yeah.
I'm just telling you, Springfield has a great new one.
So there's your rough update on EMS. Things are still, we're out here.
And you're gonna have a bill and some asks.
So we have not put together a specific ask yet. Our committee will be meeting again next week. We're kind of in that data gathering stage, trying to understand exactly what we're doing. But some of the things that we have discussed is the clarifying the billing code that we were all pretty clear on, that was in the bill to make sure that it's being paid at the emergency rate. Extending the ability for us to use that money into next year so that we can get that work done. We would always love to tackle, Medicaid rates, but we know that that's probably it's gonna be a tough one. Because I do think what's gonna come out of our study is something very similar to New Hampshire, which is that it's difficult to operate an ambulance service on currently, we're getting reimbursed. Again, in New Hampshire, they're saying 202%. Vermont's probably gonna be very close. What it means for towns, I'm sure you guys have all seen it, except for Rutland, because regional ambulance hasn't upped their rates in like 30 years. But many of the smaller services have been looking at huge increases, in some case, 100% increases in what they're asking for from local tax dollars in order to try to fill the gap that is coming from underpayment from, federal payers. So that's where you're seeing, municipal budgets take the hit when really it's a healthcare problem more so than it is a municipal government problem.
Transportation, yeah.
So
Do you get the same code when you respond to a vehicle accident on an interstate and someone that's at home somewhere having a heart attack?
we have the same code.
Like for payment? Are they
Yeah.
both considered emergency?
Yes.
Okay.
Yep. Yeah. So the way that the calls will come in, the 911 call will go with the PSAP They'll get answered and then they'll get turned over to a dispatch center. And depending on where you are in the state, there is either priority dispatching or not priority dispatching. So in our area, we do have a very kind of rudimentary priority dispatching system,
Okay.
which will let us know whether it is a advanced life support call or basic life support call, and we'll send out the appropriate crews, paramedics being in advanced EMTs being advanced life support, or EMT basics being basic life support. Not every part of the state has that available to them. So that's something else is we know is inconsistent across the state. But so in our area, based on the type of call, so for example, a chest pain call would warrant an advanced life support. So we would send a paramedic ambulance out to that. But if it was something like a fall, it would most likely be a basic life support type of event.
And are all of them two-person crews?
So for us, we send out two-person crews. There are some places that send out larger crews. So your fire-based services quite often will send multiple units, maybe a first response engine and an ambulance, which is pretty common. Some of most of the volunteer services, it will be whatever size crew is available for the day. So like next door to me, the next ambulance service by my house would be Londonderry Ambulance. They operate with a crew of 3 when they go out the door. They're strictly volunteer, unpaid. So that depends, but I would say the most common would be an ambulance going out with a crew of 2, unless it is a call like a cardiac arrest call.
Mhm.
And then most systems have a way of sending more resources in the event of a call like that.
Other questions for Drew? I'm sure we'll have you back.
One of my favorite committees.
Yeah, Senator White.
Thank you, Chair Collmore. My only question would be just the bill or potential bill that you highlighted. If you want to have a senator work on that, I'm happy to be that person.
Or committee bill.
Or a committee bill. I know that we're potentially working on a committee bill this session, so that actually might be the most appropriate place, but especially, and the extension needs to be a bill for the use of funding, or is that something?
So the way I read it, the way I read what you guys put in statute this last year, yes, but I would definitely defer to somebody that understands it better than I do.
Those legislative council members are so good. Okay.
Draft who? Draft.
I feel like it was Tucker or Tim Devlin. It was either
Okay, well, we find that.
bow tie or pin. That's how we can remember.
Anybody else have questions?
Look
Okay.
forward to continuing our work with EMS.
Are you traveling back tonight?
Yes,
Well, be safe.
Yeah.
and I'm not coming back tonight,
Good.
Okay.
That's good.
but I am coming back up next week, so.
Right. We'll see you then.
Good.
Probably in health and welfare again.
Maybe, hopefully.
Thank you very much, Drew.
Thanks.
Or here in government.
Before we adjourn, I guess we can adjourn because we're just gonna talk about the agenda. Is that?
Yeah.
Fine. That's already to
I'll
do.
look and see the agenda.
I'm trying to learn the rules, whether that's public.
No one puts their agenda setting